Good morning, sir.
This one, huh? Oh. Good morning. I'm audible, isn't it? Okay, fine. We'll start off today.
Yes,
I hope it's good with this lockdown. Anyhow, so today, this is okay, fine. So today we'll discuss a case. Say it is a case. We take a case. Say a lady named BJ. She is 34 years old, and she was pregnant for the first time after 8 years of marriage. And she was found to be having high BP at about 20 weeks of pregnancy. So around 32 weeks, the fetus is found to be smaller than the expected one. She has been referred by a local doctor for evaluation, both for mother as well as fetal, and for further management. So now this patient has come to you with two problems. See, this is a precious pregnancy because she is married for last 8 years, plus she is elderly primary. Now she has developed high blood pressure, so mother is having a problem, plus on examination what you are seeing, the child is small. So it is a case of intrauterine growth restriction. So problem is on both sides, as a mother as well as child. Now she has come to you. So now how we are going to manage this case. So today we will discuss how we are going to manage the fetus. The mother part we will be discussing it sometime else. That is, here the baby is or the fetus is smaller than the period of gestation. It is a case of intrauterine growth restriction. So you admit her, or after examining her, how to go about it. Just a minute. I find only 112 students. Next slide.
Yeah.
This is not going on. It's not changing. Slide is not changing. What happened? Just okay. This is gone. Okay. Okay. So, how we are going to manage a baby which is high risk or a fetus which is high risk? So, basically, we go for antenatal fetal surveillance. So, we'll see how to do a fetal surveillance. So, what is fetal surveillance? It's two types. One during the pregnancy, the second during labor. So today what we will discuss about the antepartum fetal surveillance, where you are assessing what is the condition or the well-being of the baby before the onset of labor. Early detection, if you do it, then what is the advantage? Then at the right time you can intervene and you can prevent further deterioration. Number of times you hear the patient was there or the mother antenatal case was there and suddenly the baby has died. You might have some other friends or from your relatives or something. Because this antenatal fetal surveillance has not been done properly, that was the reason. So here we have to find there is another side to it. The other side is the baby is normal, but because of some reason you think the baby is not well, you intervene and it may lead to a premature baby which may or may not survive. The other thing which is very important, and you should remember this, is predictive value. Suppose you do all this surveillance or you test, so whether the baby is fine or baby is not fine. Here it is, if everything is negative, that means all the tests are negative, then it's a very good chances, almost 99%, that nothing will happen to the baby. But suppose if you find that there is something is wrong, and you intervene, but there are only 50% of the chances that the baby may not be in a bad condition. So it has got a very low predictive value if it is positive, but it has got a very high predictive value if it is negative. If all the tests are coming negative, that means the baby is fine. 99% chances are that the baby is fine. But if it comes positive and you take up the baby is not good, and so fetus is not going to, you operate or you deliver the baby, when half of the time you find that the baby is fine. So it has got a very high negative predictive value, but a low positive predictive value to almost 50%. So which are the women where you see this you cannot do for all the patients, then it will be very difficult. So you have to separate or segregate those patients who requires this antenatal fetal surveillance, and who are these women who require to be put up to this. Number one, let's go by the maternal condition, where the mother already or the woman had some previous condition for which you should put them into the surveillance. Number one, as you know, is a hypertension. If mother is a known case of a hypertension, or she is a known case of diabetes, before pregnancy only she had hypertension or diabetes, or she had a heart disease, or she is suffering from chronic kidney diseases, or suddenly during that time before pregnancy she has a very high fever, or she is a known case of asthma, or she develops pneumonia or epilepsy. Other uncommon causes are she might be suffering from collagen vascular disease, sickle cell disease, antiphospholipid syndrome, what is known as APLA, or she is a known case where she is abusing drugs like say alcohol or say cocaine or other abusive drugs. The other thing is what is something problem with the fetus. Then also you go for, like in this case where given this example, the baby is small in size. Baby is a case of fetal growth restriction or IUGR. So these are the babies who should be put on fetal surveillance. The other conditions where the baby may be having, say, isoimmunization, RH isoimmunization, those also are likely to have intrauterine fetal death. So they should be also put under surveillance. What else? Like baby has got cardiac arrhythmia, or is a known case of hydrops fetalis, which may be both because of RH and non-RH causes, or the baby has got some infection like TROTS, etc. So what are the other conditions which neither the baby is having nor the mother is having, but during the pregnancy she may develop these conditions, like which is a case of a preeclampsia. That means she was not hypertensive before pregnancy, but she has developed hypertension during the pregnancy. Other condition is where she is having multiple pregnancy, or when the or it's a case of postpartum pregnancy. You all know what is postpartum. It's not the time when the expected date is over. It is not that. Postpartum means it is after 42 weeks of pregnancy. And one of the most commonest condition when in your OP, the mother comes and she says she is not feeling the fetal movement, or she is feeling very less fetal movement. Okay, so those are the patients you don't know how is the condition of the baby. So they are also should be put under surveillance. Other thing is abnormal placentation, where the placenta is not properly located, or where the cord is not properly there, or the other thing is placental abruption, where the placenta gets separated from the partial or complete separation from the uterus. So those are the conditions which can give rise to. Then when you find during examination the size, like in this case the size of the uterus was smaller. Size can be smaller because either the baby is small or the amount of amniotic fluid is less. So that will also give rise to decrease in the fundal height. And you put the patient for ultrasound, you find that the liquor is very less. So if the patient, baby is having less of the liquor, or when the liquor is excessive. So whether it is a oligohydramnios or polyhydramnios, in both the conditions, you have to put the patient under special surveillance. Or if you go by the past obstetric history, history where she doesn't know why the last baby died inside the uterus. If such thing has happened, so this is a high risk baby, and again this baby should be put in the surveillance. Other conditions, rare conditions, is polystasis of pregnancies, or whether when the membranes have ruptured, or where the diabetes has not been controlled properly, the blood sugar is not under control. So, what are the various methods by which you can do this antepartum fetal surveillance? There are different methods. Let's go into that. Number one, the clinical assessment of the fetal growth, uterine growth. So, whenever the patient is coming to you, so during the clinical examination, when you find that the size of the uterus, the fundal height of the uterus is not matching with the period of gestation taken by last menstrual period. So that's why every time when the patient comes to the OP for antenatal checkup, then one must see is the fundal height. So fundal height can be found out, either one is clinically by this method, or better it will be if you have a measuring tape where you calculate the height of the uterine fundus from the symphysis pubis to the fundal height. So normally that tallies. Suppose, and secondly, one is the fundal height. Secondly, you can measure the abdominal girth also. So this both the things, fundal height as well as abdominal girth, should keep on increasing as the period of gestation is increasing. But if you find either it is decreasing or it is static, that means the growth is not normal. So in those cases, also you will get an indication that something is not good. Second thing is fetal movement count of the mother. We'll come to this later on, how to go by it. The other method by which we go is ultrasound growth of the fetus, where you are doing the biometry. You are measuring the size of the fetus. Normally what we calculate is the biparietal diameter or head circumference, or the abdominal circumference, or what is the length of the different bones, especially the femur. Next test what can be done is non-stress test and cardiotopography. Other is vibroacoustic stimulation test, contraction stress test, nipple stimulation test. I'll be coming to each of them later on. Biophysical profile, modified biophysical profile. Then Doppler studies. Other things is fetal lung maturation studies. It was done earlier, but nowadays this is not done, because this is a where you have to puncture the uterus and take out the amniotic fluid, which may give rise to either infection or preterm labor. So normally that is not done. Other is placental grading. This is done with the help of ultrasound. So next thing what comes is when you should start doing this, put the patient under surveillance. So this is recommended when the estimated fetal maturity is sufficient. See, if you start doing surveillance, say start doing at 24 weeks, then what happens? You find that the surveillance that the baby is not doing well, or baby is deteriorating. What is the use? Because even if you intervene, you take out a baby of 24 weeks, which is unlikely to survive. So in those cases, it is no use doing. So normally it should be done after the period of viability. That means once you are going to intervene and then you find you are able to do something. So that is, and secondly, it depends upon what is the neonatal care facilities are available. See, number of countries, in advanced countries, the baby survives even after 20 weeks, but that is not normally case in our country. So that's why in our country most of the time it is taken, the surveillance start only after 30 to 32 weeks. Okay, so we should not start doing it before the period of viability. So now let's go to each and everything, those methods which I had taught. First is the, as I said, is the uterine growth. And how you do find out whether the baby is growing or not is with the help of the measuring the uterine growth. So this is both from the fundal growth, that is from symphysis pubis to fundus, and second is the abdominal growth, about which I spoke a little earlier. But next is the fetal movement count. So it has been seen that the fetal count, the fetal movement start decreasing before the baby, the intrauterine fetal death takes place. So it gives about 72 hours to you. A alarm sort of a thing comes before the baby really or actually dies. So if the baby is moving, is having movements, it is likely that the baby is fine. But before if the baby is not well or fetus is not well, then what happens? The fetus stops or it starts moving less. I've seen a small baby or any children outside also, a child who is not well. Normally what you find, he goes and lies down somewhere. The same thing happens inside the uterus also. So what happens? The baby either decrease, the fetal movements decreases or it completely stops. So how you find out that? This is very easy, and you can ask the mother even in normal cases also to do this. This thing was first started in Cardiff, a place called Cardiff in UK. So that's why this is known as Cardiff's method. What happens in this? You ask the woman to count the number of fetal movements for 12 hours, and there should be minimum 10 counts of the fetal movement in this 12 hours. So normally what you say, let the woman have breakfast, say around 8 o'clock or 7 o'clock, and after that she starts counting the fetal movement. Okay, and when 10 counts are there, then she stops for that day and she starts next day. But suppose she starts counting it from 8 o'clock, and by 8 o'clock in the night, still the baby has not moved or she has not appreciated 10 movements, then chances are there is some problem and she should immediately report to her doctor. This is one of the methods. This is known as Cardiff method. What are the other methods? In that, what happens? See, after meal, say after breakfast, she starts counting for 1 hour. And suppose she counts, say, about five movements. So that becomes the baseline. So every day she starts counting for 1 hour, or in some cases 2 hours, the fetal movement. And suppose the baseline is 5 or 4 or 3. So then, and if it is daily like that, this is fine. But one day, because of that, the movements are less, then she should be put under surveillance. The other method is, this is once in a day. The other method is after every meal, after breakfast, lunch and dinner, she counts the number of fetal movements for 1 hour daily and make a baseline how many movements are there after this 1 hour, 1 hour, 1 hour. And she gets a baseline, and when she finds that the baby is not moving as much, then this is an alarm sort of a thing, and she should immediately report to her medical attendant. So this is a simple method which can be clinically done, and anybody can do it. Now let's come to the next. Next is ultrasound fetal growth biometry. That what I was mentioning. You get the do the fetal count the fetal growth with the help of ultrasound biometry. Here, what we are doing, we are measuring the various parameters. Normally, the what is measured is basically is the head, thorax, abdomen, and walls. So in the head, what we are seeing is a biparietal diameter. So that keeps on increasing. The other is the head circumference. The third, which is normally is done, is abdominal circumference. And lastly, it is the length of the bone. Most of them are normally done is, in most of the time we do is a femur bone. So here the advantage with this is that in some of the cases, though the head is growing, the abdomen is not growing. That is what is known as asymmetrical intrauterine fetal growth restriction. So with the help of ultrasound, you can see that whether the growth is taking place or not. Secondly, whether the growth is symmetrical or not. If you happen to go to labor room anytime, you will see this machine. This is a very important machine in the labor room. What is known as CTG machine. C stands for cardio, T is photographic paper. There is a paper you can see. There is a paper. So this machine is known as CTG machine. And if you see carefully, there are transducer. One is this transducer, the other is this transducer. And there is another contraption here. So what are this? This is what you can see is the screen. Okay, so this is the screen where you can see all the parameters, and this is the paper where all these things are noted. And these two transducer, what you are seeing, number one is one which measures the heartbeat of the baby. Okay, so one is for the heartbeat. The other is TOCO. TOCO means contraction. So it measures the intensity of contraction. And the other contraction which you are seeing here, this is mother holds this, and whenever she feels a contraction, she just presses, and that is marked in the paper. So with this help of this machine, the CTG machine, what we do is a non-stress test or NST. This is very important and very useful test. What is in this test, what we are doing is we are noting the fetal heart rate. And first thing is fetal heart rate. Second, the acceleration in the fetal heart rate in relation to the fetal movement. When they are moving, when the fetus is moving, so the heart rate increases. Say in case of an adult also, what happens? Suppose somebody is sitting, then there is certain heart rate is there. So what happens? The individual gets up or starts walking, heart rate will increase. Isn't it? The same thing here also inside the uterus, when the baby is moving, the heart rate should increase normally, and that is a sign of fetal health, that baby is good. What is the rationale behind it? The rationale behind is that this is the activity of the central nervous system. The heartbeat is controlled by sympathetic and parasympathetic nervous system. So if the fetus is not well, it's not getting adequate amount of oxygen. So number one, it doesn't save the oxygen, it doesn't move much. Secondly, the central nervous system, because of the hypoxia, which leads to change in the pH, or because of other reasons also, this CNS system is not working normally. So that leads to the absence of this fetal heart rate acceleration. So this occurs because either commonest is the hypoxia. Other reason which can give rise to this is the drugs, or if the baby or the fetus is sleeping, and in case of congenital abnormalities. In those cases, you will find there is no acceleration, the acceleration is not normal. So that gives you that the baby is likely to be, is maybe not normal, in having this problem, mostly hypoxia. So normally how it is done? We count the heart rate on this acceleration for 20 minutes, and we expect that in this 20 minutes, the heart rate acceleration should occur at least 2 times, because we feel that minimum two fetal movement is taking place in this 20 minutes. So the heart rate should go up. The heart rate acceleration should be there. But sometimes what happens, the baby is sleeping and baby is not moving. So if you don't find those acceleration in 20 minutes, then you increase it by another 20 minutes. It means in 40 minutes, there should be at least 2 to 3 accelerations. So what are the other things other than this acceleration? Other is a what variables are studied is, as I said, is if normally what you see in this paper is fetal heart rate, basal heart rate, then variability because of the sympathetic and parasympathetic, the heart rate is not constant. It keeps on increasing. The heart rate variability is there. So minimum there should be at least more than 5 variations should be there. And as I said, other thing what we see is whether there is a acceleration is the presence or absence of fetal heart rate acceleration. And whether there is a, instead of acceleration, there might be deceleration. If there is a deceleration, that is also very important and it shows the health of the fetus. So there you will see that the NST is normal or the B is normal. This is what you see is if the baby is healthy, then it is a reactive NST. If baby is not, this NST is not normal, we call it as a non-reactive NST. So what happens in normal fetus is a reactive NST. When you call it as a reactive, there are 4 or 5 variables are there which you should look for. Number 1, look for the basal line fetal heart rate. Normal, what is the heart rate of an adult? It's around 70 to 80, normally 72. But in case of babies, the heart rate is more. So in case of a normal fetus, the heart rate is between 110 to 160. If it goes more than 160 or less than 110, then it is abnormal. Second thing, what you are doing is baseline variability. As I said, because of sympathetic and parasympathetic, there is a variation in the heart rate, and that variation should be more than 5 beats per minute. Then there should be 2 accelerations in this 20 minutes time, and this acceleration should be more than 15 beats per minute, and they should last at least for 15 seconds. That means there should be 2 accelerations in these 20 minutes where the heartbeat is more than 15 and lasting for more than 15 seconds. There should be no deceleration. In case of a healthy baby, no deceleration. And as I said, it should be done after 28 weeks, as if it is less than 20 weeks in half of the cases, it is even in a normal baby, it is non-reactive. So it is basically a screening test and not a diagnostic test. And if it is a positive, if you are getting a non-reactive NST, 50% chances are there that the baby is healthy, but still you are getting a non-reactive NST. But if it is a reactive NST, then it is 99.7% chances are there the baby is healthy. Good. So what this is how a reactive NST look like. If you see here, so if you see, these are the various on the top what you are seeing is the heart. You see this is not going in a straight line. Sometimes it is increasing, sometimes it is decreasing. So where you are seeing is the red arrow. It's not very clear, but still you can make out where there is a red arrow, and so the heart rate is going up and it is lasting for more than 15 seconds. And if you see in this time, there have been almost 4 to 5 accelerations. So this is a reactive non-stress test showing acceleration. This is showing the fetal heart rate, and the arrow points when there are accelerations are there. So what is the another test is vibroacoustic stimulation test. As I told a little earlier, what happens in some cases, the baby is sleeping, so within 20 minutes you are not getting acceleration. Then you have to wait.
Hello, everyone. Hello.
Hi, ma'am.
Hello. Yeah, there is a power cut in the college, so because of that, there's a outage. Please wait. We are trying to
Okay.
reconnect. Okay.
Okay, ma'am.
This conference is no longer being recorded. This conference will now be recorded.
Hope you are able to hear me. So, sorry for the interruption. So the other thing, as I said, that takes the baby or the fetus may go into sleep and it may take a long time. So to overcome that, there is something known as vibroacoustic stimulation test. So in this, what is done? There is a small contraption which produces shrill sound of about 80 to 100 decibel. Okay, and for 1 to 2 seconds. Because of this loud noise, the baby the fetus which was sleeping, it suddenly gets up. So it reduces the testing time and the false positive test. So it's only in 2% of the cases that still the baby will not get up. So this is to shorten the time, and in case of for the sleeping baby, this contraption is used. What is next is a contraction stress test. This contraction stress test is not done nowadays. Here, the stress is put. How the stress is put? The rationale behind is the uterus start contracting. With the contraction of the uterus, there is a stress. So that is how it is done. So how the contraction can be produced? To see the response, because what happens during contraction, once the uterus is contracting, the intrauterine pressure increases. So because of the contraction, the blood supply to the fetus is minimum or no supply. So what happens? A baby or a fetus who is fine, they can withstand this cutoff of the oxygen supply. But a baby which is already compromised, they are not able to withstand this hypoxia because of the contraction. So what we do is we see the fetal response in response to the uterine contraction. So because of the contraction, the oxygen supply is transiently cut off. So what is the indication when you do it? When there is a non-reactive stress test, then you do it. But you have to be very careful before doing this. Why? What is the problem? What will be the problem if you do with this? If you go for the contraction stress test. The thing is, first danger is the risk of preterm labor. Say a patient who has got a risk, who might have gone into earlier also into preterm labor, they may go before the time, they may go into labor and you may not be able to stop the labor. Because after normally how you bring the contraction? You bring the contraction with the help of drugs like oxytocin. Once you start a oxytocin, there is a artificial uterine contraction starts. But you have start with the with oxytocin, and once you want to stop the contraction, you switch off this oxytocin drip. But the labor pain continues. So there is a chance or a danger of patient going into preterm labor. Second is because of the excessive pressure, the membranes may rupture, giving rise to premature rupture of membrane. So obviously, a patient will have a preterm delivery plus all the danger of premature rupture of membrane. Then what are the other problem? Where the uterus has undergone major surgery, like say classical cesarean section, where you give is a vertical incision, or patient has gone a other operation like myomectomy, or repair of the congenital abnormality. In such a case, because of this artificial induction of the contraction, the uterus may rupture. So there is another. Then what are the other problems which may occur with contraction stress test? Is in case of a placenta previa. So in case of placenta previa, multiple gestation, cervical incompetence, vasa previa. So what happens in case of placenta previa? Since the placenta is sitting in the lower segment, with the contraction, the patient may develop antepartum hemorrhage. Or in case of a multiple gestation, she goes into preterm labor. Or if it is a case of a cervical incompetence, patient may develop premature labor. So what happens, how you do it? You start with oxytocin drip. That means in one bottle or in 1 pint of Ringus lactate, what you do, you put about 5 units of oxytocin and you start with the drip. So once you start getting 3 contraction in 10 minutes, then you don't increase the dose of the oxytocin. So as I said, this is rarely done nowadays. And when it is negative, when there is no late or variable deceleration, because there should not be any deceleration. If there is a deceleration, then this becomes positive contraction stress. But if there is no deceleration, whether late or variable, then that shows that the baby is healthy. In positive, and suppose there is a late deceleration, so it doesn't mean that the baby is not well or fetus is not well, is not healthy. In half of the cases, they are healthy, but still you get is a late deceleration. And what is nipple stimulation test? It is same as the contraction stress test. Only difference is, instead of oxytocin, here the nipple is stimulated, which leads to the release of oxytocin from the brain or from the pitocin or oxytocin is released. So interpretation remains the same. So what happens, suppose you have done this non-stress test or contraction stress test and you find it is not normal or it is positive, then what next you do? You do is to find out the fetal health, condition of the fetal health, you go for biophysical profile. So what is this biophysical profile? Here various parameters are seen. In this biophysical profile, 2 things which you do otherwise also are very important. Just 3 are not as important, though each parameter is given 2 marks. So 5 parameters, 10 marks. You give scoring of 10. So out of this 5, 2 are very important. One is non-stress test, which we have described earlier. If it is a reactive, then you give 2 marks. That means if there are 2 accelerations, more than 15 beats per minute, lasting for 15 seconds in 20 to 40 minutes, then you give 2 marks. If there is only 1 acceleration or no acceleration, then you give 0. This is one of the very important parameters of biophysical profile. The other is number 5, as you see, amniotic fluid volume. This is another very important parameter. Here, what you see, here you see the single vertical pockets of amniotic fluid, where the fetal parts are not coming. Here you take the maximum length. If it is 2 centimeter or more, you give 2 marks. And if it is less than 2 centimeter, largest pocket is less than 2 centimeter, then you give it 0 mark. So these 2 are very important parameters. The other things what you see is the fetal breathing movements. 1 or more episodes which is lasting for 30 seconds of the fetal breathing, if you see, you give 2 marks. If it is less than 30 seconds or no fetal breathing is seen in ultrasound, then you give it 0 marks. Third is fetal movements. So you should be able to see 3 or more discrete body movements, which is in 30 minutes. In 30 minutes, if you can see the fetal movements, then you give 2 marks. And less than 3 movements, then you give 0. Other is fetal tone. What is this mean? How you find out the fetal tone is good or not? So what you see whether the limb is extending. That means normally the baby is in a flexion mode. Or if you see the knees or in the elbow, they are flexed. But if you find the extension is there, or the opening and closing of the hand, within 3 minutes, if you find, then you give 2 marks, or otherwise less than that, you give 0 marks. So this is how you do is a biophysical profile. So if the it is more than 10, if it is 10 or more than 8, then it is good, 8 to 10. But if there is oligohydramnios along with this, then it should be repeated every week. That means for 1 week you can forget it. And if it is around 6 movement, then if the baby is more than 36 weeks, deliver it. If less than 36 weeks, you keep doing this twice a week. If the score is 4 or less than 4, then you deliver the baby by cesarean section. Don't go for a trial of a normal delivery. So see, all that biophysical profile, that takes quite a bit of time. So it takes almost an hour. So nobody has got that much time. So now what they have done, they have made it into a biophysical profile, modified biophysical profile. In this, only you take 2 parameters, that is combination of NST and amniotic fluid index. So it is just requires about 10 minutes to do. And if it is reactive, and see, NST is reactive and amniotic fluid is more than 5, amniotic fluid index. Here what you do, what is the difference between this and the previous one? Amniotic fluid index, you divide the uterus into 4 quadrants and you take the maximum pockets of the 4 and combine them. If it is more than 5, then it is fine, it is reactive. If the AFI is less and NST is non-reactive, then nowadays we are going back to biophysical profile. So initially, nowadays what we do is a modified biophysical profile. If it is abnormal, then you go for a biophysical profile. So after that, what is the other test that can be done is Doppler studies. So this is a non-invasive and it has become very useful. So what is the Doppler study? In this Doppler study, basically we see the flow of blood or the velocity of the blood flow. So fetus gets blood from where? The uterus gets it from the uterine artery. And from the uterine artery, it goes to the placenta, and with the help of the cord, umbilical vessels, it goes to the fetus. So what we see is basically what is the velocity of the blood passing through this. So the common what we use is the umbilical artery. In the umbilical artery, we see what is the flow of blood. And the other artery which we see is mid-cerebral artery. Mid-cerebral artery, with the help of the blood flow in the mid-cerebral artery, we can find out what is the condition of the brain, whether the brain is getting adequate amount of blood or not. And the other is ductus venosus and umbilical vein. These are seen in cases of a fetal growth restriction, and this is almost at the terminal stage that you find this is abnormal. This is how this looks like in case of a Doppler studies. In Doppler study, see what you are seeing here is the 1S stands for denotes the systolic, and this is the diastolic. So during the systole, the amount of flow is much more, and during the diastole, the flow of the blood is less. This is what is seen in normal condition. But what happens if the resistance is there? Then what happens is there is the diastolic, the blood flow during the diastole, it decreases. And as the resistance keeps on increasing, either this blood flow during the diastole is decreased, or there is no blood flow, or in the terminal condition it becomes That means there is a reverse blood flow. So that is a very in the terminal stage. So various indices are made and you see. So the diastolic keeps on decreasing, systolic remain the same. So all these indices, they keep on increasing. So as there is an increase in the indices, that shows that there is a problem in the blood flow and the health of the baby is not good. So basically what we see, now I will cut short, is uterine artery Doppler, then we see is the umbilical artery Doppler. So these are the various things. As you can see, on the what you are seeing is the cord, the blue thing what you are seeing, and red. Red is where the blood is coming towards the transducer, and blue is where the blood is away from the transducer. And on the umbilical vein, you can see the various notches are there in the umbilical artery. So a absent of the flow in the shows that condition of the baby is not good and baby should be, pregnancy should be immediately terminated. This is what you are seeing, the flow is in the reverse direction. If you see this diagram, you can see this waveform. Instead of the positive, it is the negative side. That means blood is flowing in a reverse direction, which shows is a very bad sign, and blood flow is reversed and needs to be, baby fetus needs to be delivered very fast. So what is the timeline for this? When what happens if there is a baby's growth is abnormal, then first thing what will become abnormal is the Doppler study. And after, in the Doppler study, first is the arterial Doppler will become abnormal, followed by venous Doppler. And once you are getting abnormal NST or biophysical profile, that is in a very late stage. So with the help of this surveillance, you can find out what is the health of the baby and you can intervene at the right time so that you don't end up with intrauterine fetal death. So what is the take-home message? Basically, this surveillance is basically to prevent the fetal demise. So the second thing is you want to prevent fetal death. Second thing is you must do this only for the high-risk patient. What is the normal thing you do first is the non-stress test that looks for the fetal heart rates acceleration. The other is a contraction stress test where you induce artificial contraction. But nowadays that is not done. Nowadays what is done is you ask for modified biophysical profile. If it is abnormal, then you go for the complete biophysical profile. Fetal umbilical artery Doppler, you see the velocity and it is very useful in deciding when to deliver the baby. And middle cerebral artery Doppler is useful to find out whether the brain is affected or brain is not affected. Thank you.